I think we need a big hand for everyone. This was amazing. I'm going to ask the judges to leave for their deliberation. And I don't know how long they're going to be gone. I think this is going to be difficult. It's going to be somewhat of a little fight, I think, depending on personal choices. And once they leave, we're going to open the People's Choice Award voting. Alors, préparez-vous pour le prix du public. Does everyone have a ballot? Est-ce que vous avez tout ce qu'il vous faut pour voter? Yeah, okay. Our contestants, yeah, everyone.
And our two assistants, Rena and Katrina, will take your ballot.
Okay, so you simply check off the box next to the name of the presenter on the paper ballot that you received with the program. Pour ceux qui regardent la compétition en ligne, vous pouvez voter pour le prix du public via le lien présenté dans la description sous la vidéo. Sure. Okay. I think we're going to start the questions because we heard such amazing talks. So whoever is asked the question, please come to the front because we do have microphones so that everyone can hear you. So I had a question for Michael. I'm a biochemist. I didn't know peroxisomes had DNA. So can you tell me more about it? Is it genomic DNA? Is it, or is it like mitochondrial?
No, so you want me to dispose?
Just leave it, okay.
So basically, what I did just to simplify the presentation was we actually did genetic silencing and a technique called CRISPR. Basically, you can disrupt the DNA corresponding to peroxisomes. So we actually went into the genome and did it. But to simplify the presentation, rather than explaining a complicated genetic technique, we also did silencing of RNA. Because of the limitations of time, I said that we broke the DNA.
Got it.
Yeah.
Okay. I thought I had a huge lack in my background. Yes, we have a question up there. Jay, do you want to come down?
Okay, so the question was, how do placebos work even if they know that it's a placebo? And there's this field called open label placebo. And this is when you give somebody a placebo, either a pill or some kind of treatment, and you tell them that it's a placebo. But placebos seem to work through a bunch of different functions. So part of it is just the expectations that you have. So when we brought the kids down into the hospital, we showed up in lab coats, and we had them wait at the front, and the assistant walked over, and we sort of did all these traditional medical rituals. And when people experience all of these rituals, they're expecting that they're going to heal from this. So sometimes it matters less what the pill is that you give them, and it matters less whether they know that there's nothing inside, because it's the entire environment, it's all of the cues, all of these medical rituals that help them heal, and not just the pill itself.
I think there was another question. Yeah.
Scott. Can you maybe compare contrast? So you're isolating these stem cells from, as you mentioned, the kidney or bladder or something.
Yeah.
Are they better for conditions from that region as opposed to sort of transition to the brain? Can you sort of compare and contrast that to just from other?
So just to be clear, you're asking like, are they better at like sources of us for stem cells than other areas like the brain, or?
No. So if you're using them, you know, there are multiple stem cells that are coming from a certain organ or tissue.
Yeah.
are they better to treat ailments from that tissue of organ?
Okay,
Or are they better for, like, what makes them better than just an iPS cell? If you're putting them in an exogenous location, what makes them better than
Yeah.
something for that?
That's a great question. So the main factor for us in why urine is better is because it's way easier to acquire from a large amount of people, and it costs way less because you don't have to get surgeons involved, and it takes way less time. Theoretically, any source of stem cells that you can get from the body, whether that's from skin, from blood, from urine, if you keep it in a stem cell state long enough, should be suitable to do any kind of stem cell work you want. A lot of that time, that's not the reality because people can't keep stem cells indefinitely because it's very expensive. In order to help mitigate that cost, that's why that's where we started being very excited with urine in the first place, because to go from something like skin, where a lot of purification takes place, it usually will take us 2.5 months to go from an actual patient to a nice stem cell population that we can use. With urine, we can do it in about 3 weeks.
Okay, so I had a question. How much urine?
Okay, that's a great
For
question.
each a little bit?
No,
of-
that's a great question. So when when people start first working with urine in the context of any kind of cell culture, you used to have liters of urine in order to get any kind of appreciable amount of cells out of it, because the cells died and people didn't understand what they were really working with. And that's problematic because you can't get a liter of urine from someone usually unless you're following them throughout the day. But if you can enrich the cells that you're dealing with through cell survival and by actually processing the cells that you have to grow and differentiate, we currently work with about 80 milliliters, or your standard drug test kind of urine sample, which we can even get small kids to give us sufficient amount of cells.
Yeah, there's a question.
Scott, so you mentioned that you need some drugs or chemicals in order to increase the survival of the stem cells in urine.
Yes.
So how would that work? Would the person take the drugs, or would you put it in your culture?
Yeah, so, that was another big question. And actually, we had to partner with Stem Cell Technologies, which is a company out of Vancouver, for that. When we originally did it, we would just always have collection within our own lab. So we'd go and we would just put in these survival factors essentially into the urine, and then we could deal with it over the next couple of days. When we started dealing with patients that were located in some places very far away, like Vancouver, we actually went and developed pills that we could just issue along with the standard collection kit. Like sometimes if you have a very small child, it can be difficult to collect urine, so you just package it up so that people pee, pop a pill in, and then you're good and set to go. You've increased the survival time long enough so that if you chill on ice, you can ship it to us in Montreal, and your cells aren't going to just die.
J'avais une question pour Fanny. Combien de temps est-ce que ça a pris à développer le premier dictionnaire? Et surtout quand ils ne pouvaient pas communiquer, les Huron-Wendat, avec les missionnaires? Est-ce que tu veux venir en bas?
Il y avait d'abord des traducteurs, comme des truchements ou des autochtones qui avaient été en France, par exemple, étaient revenus et pouvaient déjà communiquer. Il y avait aussi un autre ordre missionnaire avant les Jésuites qui s'appelle les Récollets, qui ont, pendant 10 ans, pas juste avec les Huron-Wendat, mais avec d'autres peuples autochtones aussi, comme réussi à faire les premiers dictionnaires. Quand les Jésuites sont arrivés, ils ont fait une collaboration avec les Récollets, collaboration aussi avec certains truchements. Puis assez rapidement, c'était des notes un peu.
Alors, des échanges.
Des échanges, un peu des notes. Puis ensuite, ils ont très rapidement travaillé à un dictionnaire qui a été perdu et qui a probablement été raffiné parce que ceux qu'on a, c'est quand même bien fait.
D'accord.
Une
Merci.
autre question pour Fanny, peut-être.
Oui.
Il se trouve où, présentement, les dictionnaires? Ils sont à Québec ou à Montréal? Ils sont dans des musées ou des archives?
Il y en a un à la John Carter Brown Library aux États-Unis. C'est le dernier dictionnaire à avoir entré dans une bibliothèque en 1931. Les autres, il y en a 5 environ aux archives du séminaire de Québec à Québec. Il y en a un aux archives de Saint-Sulpice à Montréal et il y en a 3 aux archives jésuites à Montréal aussi.
Tu les as consultés, c'est ça?
Oui. Ben, il m'en manque celui à la Jennifer Wonderberg
Ok.
cet été.
Bravo.
Merci.
Est-ce qu'il y a d'autres questions?
Yeah.
I have a question for Sherry.
Sherry?
So you mentioned that obesity increases the permeability of the blood vessels in lungs, which is why it's causing it to develop there. Can you explain how that works and if it also appears in other organs as well?
Well, we don't know exactly how it's increasing the permeability or the leakiness, so that's the next step of what we're trying to figure out. And it could be altering things that are important for the structural integrity of the endothelium in blood vessels. And it does appear in other organs too. From this experiments that I've done, organs like the brain, different organs, it does definitely occur. I'm just focusing specifically on the lung because it's easy to focus on one place, but yeah, it does occur.
So maybe if you just stayed, so how do you do the 3D bioprinting?
Well, technically this is how it normally works. You would get like a metal wire, and the wire can have like any sort of diameter. And then if you seed cells, like kind of like underneath, you have a chamber with cells, and the cells will grow around the metal wire. And then when you remove the metal wire, you have like a lumen and cells around it, and that's normally how it would work. Yeah.
Okay.
Yeah.
Thank you.
Any questions? Peut-être une question pour Gabrielle? En 3 minutes, ça passe vite. Alors, la question, vous avez 6 variants déjà que vous avez identifiés et vous connaissez les gènes, je
Les 6
présume,
variants sont situés dans 3 gènes,
dans 3 gènes.
mais je peux pas en parler.
Non, ça va.
Donc, en gros, on a trouvé 3 familles différentes. Plusieurs familles qui ont 2 à la fois ont un variant dans le même gène. Donc, c'est pour ça que ces variants sont intéressants parce que je les ai trouvés à la fois dans 2 familles différentes.
C'est indépendant, oui.
Et c'est pas les mêmes variants, mais c'est le même gène.
C'est
C'est
le
pour ça que j'ai priorisé ces variants-là dans mon étude.
D'accord.
Josephine, People's Choice Award will close for polling in 2 minutes.
People's Choice Award will close in 2 minutes for people who are online. Just announcing it. 2 more minutes to get your votes in. All the paper votes have been tabulated already. Choix du peuple. En 2 minutes. Vous avez moins de 2 minutes pour voter. Yes.
Karina. Can we talk a little bit about, so there's like 100 different HPVs, and they know there's a few of them that cause certain cancer, that are associated with specific cancers. Is there vaccinations against each of the ones that are associated with cancer incidents? Or is there not, or is there, you probably know that, I don't really know the intricacies of those specific.
Yeah, so the big ones are 16 and 18, and the first vaccine that came out covered those 2, then the next one covered the 4 key types, and the newest one, the non-valent one, covers 9 types, which covers essentially the gamut of the HPVs that cause the cancers associated with it.
And they're giving to women in their 20s, is that?
They can, but actually there's school-based programs starting like age 10, 11, 12 across the provinces, and there's some provinces that will start vaccinating boys as well.
That's Scott.
I was just wondering, so as I understand it, for like infectious risk in cancer, which is not my field, that infectious risk contributes very, very heavily to very specific cancers.
Yes.
And maybe a little bit in a very lower, more base weight, some of them more, to many other ones. Do you know what percentage of like the global cancer burden can be directly attributed to infectious?
Yeah, so over the years, starting in cancer incidence in 1990 up to the most recent year available, 2012, it's between 15% and 18% of the world's cancers are attributed. Canada, we're lucky, and same with the USA, because it's so developed, the proportion is much lower, below 5%, but some sub-Saharan African countries, it's as many as half of their cancers are attributed to infections.
And what kind of infections are really like making up that difference? Is it?
HPV plays probably globally the largest role, and then that's the case in North America. Helicobacter pylori, it's a bacteria that can cause non-cardiac stomach cancer, is the second biggest one.
So if we know that HPV is causing most cervical cancer cases, like you may not know this, but why hasn't it been like the vaccine been implemented? Like children once they're like 11, they get the vaccine.
They do, in school-based programs. Now, they are able to opt out of it, so if their parents say we don't want that to happen, there's that option. So coverage rates aren't what we had hoped they would be. And part of that, increasing that, will be getting a message out that they don't cover. It's strongly related to these cancers and highly transmissible, but
Is this only in North America, or is this like
the vaccine?
Yeah,
But throughout the world. Not every country, but it's available in different formats though. School-based programming, not as much, but through different programs.
Sorry to keep bombarding with questions, but what's their coverage rate for like Canadians? Like you said that like their coverage rates are not what we would hope for because people opting out. Are a lot of people opting out? Like so that their children don't receive the vaccine is a very substantial part of the population.
I'm not sure about the total coverage across Canada and the United States, but it's falling below 80%, which was the initial target, and then some places like Toronto, the opting out is a lot higher, and it can fall well below that.
So what percentage of boys are vaccinated nowadays?
I don't know. Does anyone from, sorry to put you guys on the spot.
In the provinces, it's too early to tell because they just
Okay.
implemented it.
Okay.
It's lower than in girls usually because
Yeah.
people are not as aware that HPV causes cancers in men, so they're not as prone to vaccine.
Okay. Okay, thank you.
Yeah, there's a question up there.
I have a question for Hannah. Is my protocol offense?
Yeah, we squeeze in everything.
Hannah, what's the trigger between the big breath, the enormous numbers of people in that reservoir of your iceberg and the tip of the iceberg?
Well, it depends. I mean, there's a lot of the clinical side that, to be honest, we're still working on understanding better why people go on to develop active disease, but a big component is lowered immune system responses. So people who are HIV positive, who primarily, in the rest of the world, like sub-Saharan Africa or Southeast Asia, that tends to be the biggest driver. Also, children who are under 5 are at much higher rates, or are much more increased risk of developing active TB. So the World Health Organization currently prioritizes those two groups. So technically, people who are HIV positive and children under 5 who are in close contact with someone who has latent TB are supposed to be given preventive treatment, but it's essentially not happening. Like my research in Indonesia showed it's literally 0% of people's time right now is nobody's getting preventive treatment. So that's why we're trying to change that, particularly with kids.
Thanks. There are many more questions. Okay, one up there. Yes.
Do you know why is it expensive to get preventive?
No.
I'm from Brazil and you mentioned Brazil.
Yeah. Okay. Well, so no, it's not expensive. The traditional treatment is 6 to 9 months of isoniazid, which is an antibiotic that's actually available freely. There's some stockage problems, but it's available in most countries. The main reason has been, so actually what I looked at, I did a systematic review and meta-analysis looking at sort of the reasons that people aren't getting on treatment, and a lot of it has to do with there's a big loss of people because we don't actually identify them. So I kind of tried to make it succinct in my presentation, but basically part of the reason nobody gets treatment is that nobody gets identified. So people who have active disease come in to get treated, but there's stigma around telling their family members that they have TB. Furthermore, there's not necessarily a priority of getting preventive treatment, right? Like we all know, even when you're sick, taking antibiotics kind of sucks. So if you're told you have to take 9 months of preventive treatment and you don't feel sick and you're not contagious, it's hard to motivate people to do that. However, getting active disease is a motivator because it's much harder, and in many countries also, they're more likely to have multi-drug resistant TB if they get active disease. So that's even longer treatment and much harsher. So that's, again, the reason for prevention.
Do you have a question, Scott? Yeah.
TB used to be way more widespread, right? It used to be pretty much in every country in the world. I guess for the population, maybe it is, but far less active prevalence in developed nations. Was that just due to people being able to identify effective drugs and like doing nationwide campaigns, or was there like, is there changes in, say, like how hygiene is regulated in like our particular societies that really led to a decrease in spread?
I mean, the major reason that's changed, particularly in the West, is that you had the advent of antibiotics, and for a long time antibiotics were sufficient. There's also more antibiotic options in developed countries like Canada and the US, and so getting access to treatment for active disease is harder in other countries, particularly shorter treatment regimens. But yes, it's also linked to a lot of socioeconomic factors, so hygiene, but it's not necessarily so much the hygiene, but it's really the living conditions. We're also finding out there's quite an interesting link now between things like nutrition. I mean, this was probably already obviously a problem, but really nutrition, smoking, in fact, and diabetes is also linked to increased activation from linking TB to active disease. So there's just a whole host of factors, and the reality is in most of these countries with a burden of active TB, a high burden of TB, they have problems getting resources for everything, so it kind of all plays together. It's sort of unfortunate.
Thank you. So I had a question for Surashri.
So I love the Spider-Man and the web, but I couldn't quite understand what is the web that's made for trapping the cancer cells and the interplay in there.
So basically the neutrophils release their DNA, and these webs of DNA are actually really sticky, and when you look at them under a microscope, they look like a spider's web. So that's how they're functioning. The main thing was they were made to trap bacteria and pathogens, but now research is sort of focusing to see what's the role with cancer cells, and do they trap cancer cells, or are cancer cells escaping?
Okay, so so it could be either way.
Okay, thank you. Yeah, there's a question up there. Yeah.
I'd like to ask Rami a question. So I'm not going to talk about potholes. But do you see a day when we won't need to use concrete for bridges?
We won't need to use it as any one replacement material.
Yep.
Well, the first thing you have to understand for concrete is that we need a lot. Like every country uses concrete, and it's the most used construction material by like 10 times. So steel is like 10%, and that's widely used, right? So the main issue is, it emits carbon dioxide, and it eventually recaptures that while just standing and existing. But we don't have as much everything else as we do concrete, because concrete is just made of rocks, pretty much, and it's rocks and cement, which comes from Earth. So there's a lot of rocks, and
In Quebec.
in Quebec as well, yeah. So it's really easy to make, and that's it's so prominent that we use it for everything. So if we do use another material, we either will use it just like as a fancy thing or like in a specific location, but not everywhere else. And the cost will be probably a lot higher. Nice.
Okay, one last question, because the judges are back. Can you imagine?
I'm just trying to get everyone in to get a chance to answer. Who's left? Matthew. Go this way, guys. Let's take the last question.
Yeah.
So, if you're looking at metabolism in the context of GBM, are you interested in the contrast between IDH1 mutant and wild-type GBMs? Because one is driven by an metabolite and the other one isn't.
Yeah, for sure. And that's a very significant, one of the many mutations in glioblastoma that can kind of result in how the tumor plays out. And it's not one that we really look at so much in our lab. Glioblastoma itself is very, very heterogeneous. There's all kinds of different mutations that can result in glioblastoma tumor formation. The one that we kind of look at the most in our lab is the Egfr V3 mutation. It's a growth factor mutation that is always active. And the reason we look at this is because we find that the oncostatin M receptor binds with this complex, and then you get this signaling complex that is just continually shouting, all right, let's go, let's grow, let's grow, let's grow, right? And that mutation happens in about 50% of glioblastoma. So that's the one that we really focus on the most. I've done a little bit of looking at IDH1, IDH2 mutations, but it's not really the core focus of our lab.
Thank you.
So, we're going on with our session. Avant d'annoncer les lauréats, il faut absolument que je remercie beaucoup de gens. Et je vais commencer avec les membres du jury. Merci beaucoup. Un très gros merci pour avoir fait ce travail acharné, difficile. Merci beaucoup. Is that me? No. Okay.
A little too excited.
Yes. Is it because of this? Okay.
Thank you.
Okay. Fine.
It's pretty good acoustics in here, so it's okay.
Yeah. I'm going to have a whole list of people, so we'll applaud at the very end. Otherwise, so many people have made this such a great occasion. So I'd like to really thank the event planning team at SkillSets and GPS, especially those in front of you. Sophie Marie, Alistair, and Olivier. We don't recognize them because they look so specific, especially the men. I mean, Sophie Marie always does. They've done an amazing job. They've been at this for months and months and months, and I think it showed how it was a well-oiled machine. Terrific. Thank you very much. Kashif Khan, who was one of our, was last year's winner in the 3MT, and he was also the Eastern. Oh, there he is. I didn't recognize, you know, with the suit and everything, right? He was also the Eastern CAGS winner last year, and he's done so many events for us, orientation, everything else, and he was involved in the training of the students. All of the other McGill staff and students who gave feedback, because for all the sessions, when I said group feedback, people were involved in giving group feedback, then the one-on-one feedback. I hope you agree that it's worth the work that people have done. I guess you guys think you've improved, have you? You were superb. I don't know at what level you started, but you were superb. The support from alumni relations and the communications and external relations, and all of you for coming out. I mean, you know, I think it takes courage to put yourself out there, and you did an incredible job. So big round of applause. We have the decisions? We do, okay. Okay. So the 3MT, our representative to the CAGS, Eastern Regional Competition, is Jay Olson and his placebo machine. Congratulations. Thank you. Got the big thumbs up. Congratulations. Yeah, you can stay up here because we'll take pictures afterwards. Ma thèse en 180 secondes, Gabriel Hull. Alors, il y a un voyage à Chicoutimi au mois de mai. And we have the people's choice. I guess many votes, right?
Many.
Online and in here.
Close to 300.
Close to 300 votes for the People's Choice Award. It's Sarashli Shinde and her Spider-Man web. Congratulations. Thank you. Thank you. So do we need a picture just with the 3 winners?
Yeah, if you'd like to come stand out in front of the podium.
Yeah.
Should be a quick one for you. And then we'll turn it over.
Turn it over.
Yeah, and then just walk them over right to your side.
Okay. Yeah. Okay. Thank you very much. So we're all ready for our big celebration, the reception. I'd like you all to join us. You can follow Alistair into the museum for this for the reception. I want to say thank you to all of you for coming out. Every year I say it's the best. I don't know, it is the best that we've had. It's been incredible. Thank you for participating. Without you, we wouldn't have had the competition. Thank you to the judges and thank you to the audience for coming and supporting everybody. So we really hope that you will stay for the reception. We're looking forward to talking to you, and you can talk to all the presenters at the same time. Thank you very much.
I can take all of those.